Welcome to State of the State. I'm Darlene DeRezzo, and I am in conversation with Mike Cerullo, one of my favorite guests. I think I've spoken to Mike now 3, 4, 5 times. Mike is a lifelong Rhode Islander. You went to school at LaSalle.
Correct.
Following that, you attended Brown University. After a career in sales and marketing, you entered the master's degree program in human development, counseling, and family studies at URI. That was in 1990 that you graduated?
Yes. Yes.
You're also a former member of the Exeter Town Council and the Washington County Regional Planning Council.
This is correct.
Okay. You are a national certified trainer in both youth and adult mental health first aid, which we've talked about on this show.
Correct.
Let's see. You train educators, youth workers, police, first responders, and veterans in mental health first aid.
Yes.
You've also conducted continuing ed and in-service training workshops on adolescent mental health, marijuana issues, and addiction for Rhode Island College, the Graduate School of Social Work, the Rhode Island State Police, the Rhode Island Department of Children, Youth, and Families, and the Rhode Island Family Court, where you've actually done parent-child assessments, correct?
That's correct.
Correct. All right. What did I leave out?
I'm a grandfather and now a great-grandfather.
Congratulations.
I have 9 grandchildren and a great-granddaughter.
Congratulations. Mm-hmm. That's wonderful. Okay. So let's start with mental health training and mental health care for first responders and law enforcement, right? So this show will likely air in May. May is Mental Health Awareness Month. Mm-hmm. We had Bud Cicilline on to talk a little bit about that. And you're going to pick up where that conversation left off, right?
That's correct.
Take it away, Mike.
So I'm glad you mentioned Bud Cicilline, because when we were on the Mental Health Association board. And about 10 years ago, we did a research study on the perceptions of Rhode Islanders from various segments of the state and different areas of the criminal justice and justice system in terms of the perceptions of Rhode Islanders involved with the mental health system and the juvenile justice system. And during that period, it was clear that one of the things we needed to do is to help public safety people gain a more in-depth understanding of what a person experiencing a mental health challenge might be going on with them and what they might need to know in order to help them, whether it's to divert them to a program, to get them back into their own program, ways in which to divert them out of the prison system, because that had become, over a 20, 25, 30-year period, the biggest single mental health institution we had in the state. And from the 60s, we had about 3,500 people in mental health programs, mm-hmm. LAD Center, the various group home settings. And then by the time we did this program, we were down to 150 people in programs for residential programs for individuals with mental health challenges. During the same period, we went from 483 people imprisoned throughout the state to well over 3,200. So essentially what happened was there was a shift, mm-hmm. okay? A lot of that had to do with deinstitutionalization. A lot of that had to do with not bringing the funding that was being used in the institutional world mm-hmm. out into the community, right. Which is where it was supposed to be. So,
right. So was this a result of the Kennedys
yes.
signing off on the Mental
right.
Health Care Act? I got that right in the 60s. And also, there's a lot of faith being put into new antipsychotic medications.
Correct.
Maybe too much faith.
That's a very good point.
Yes.
And absolutely. So that's the context societally in which the conversations now emerge over the last 10 years in Rhode Island about what we need to do to help public safety. Mm-hmm. What do we need to do to avoid adding to that population in prison. So what happened was that the General Assembly, through the activity of a particular Rhode Islander who actually had a great deal to do with the curriculum, a retired Warwick captain named Joe Coffey, one of my favorite people. We've trained together, we've done trainings together. In any event, through Joe's efforts, he was able to get the General Assembly to require, beginning in 2016, that every sworn police officer in the state would undergo 8 hours of mental health first aid training. So we have this mental health first aid training we've talked about over time. And it's an 8-hour curriculum, and it talks about mental health and giving mental health first aid to individuals with those challenges, pretty much in the same way we do CPR. That's the basic idea. It's an international model, accepted and used in 25 countries. And so here we are. Now we have a police, every policeman in the state and woman in the state is now being trained at the academy. You don't finish the academy without taking this 8-hour course. In the meantime, we've been training all of the others in the state who hadn't had the training. So, for example, we had large grants in Washington County. We have now trained every single sworn police officer in Washington County. I've trained people, DEM's police force, Cumberland Police Department, Barrington Police Department. And there are many other trainers in the state doing the same thing. So that's what we've done with training. Along the way, since you mentioned fire EMS, the Center for EMS has now required that every licensed first responder, EMT, will, in order to relicense, to get their recertification, undergo a similar program designed for fire EMS personnel in order to get their license. So it's an 8-hour training, and we conduct those. I've trained probably 200, okay? And we've done this through, this is being done throughout the state. And the state actually is doing it themselves as well with certified mental health first aid trainers. So what's this mean? We've got this model, 8 hours of training. In both of those models, there's an internal focus, that is to say, what do we need to do to help officers and EMTs stay emotionally well? Get into more detail about that in a minute. As well as what do they need to know in order to interact in either of those roles with someone in the general public who is having an emotional challenge. Okay?
Or a psychotic episode.
A psychotic
maybe
episode.
Hearing voices or seeing things.
Let's take a psychotic episode, because this is really critical. So first off, we need to remember that psychosis is a symptom. It's not a condition. You can have psychosis with heavy-duty depression. You can have psychosis...
Drugs.
Drugs. You can have psychosis with conditions like schizophrenia or bipolar. Okay. So now you are called, let's take a policeman. Part of our training would be that you're called to could be a homeless person. It could be a parent calling and saying, my son went off his meds. It could be a lot of different things. And you present there, you show up there, and the person is talking about these guys over there in the corner who are trying to pick my brains. They implanted something in my brain, and they're trying to drain all of that. Or I was just taken up into a spaceship. These are real cases. I've worked with individuals who've been through this kind of thing. So now, how do you handle that? Well, what we do is we teach folks these professionals to enter the conversation with the psychotic hallucination. Let's say it's an auditory hallucination. We suggest to them that they do not push back on that person's beliefs. That's their reality. We affirm that. We validate that that is what they are experiencing. Well, why would you do that? Well, if you're talking to somebody who's having auditory hallucinations, it's a pretty good idea to find out whether those auditory hallucinations are telling them to do something.
If they're command hallucinations.
Yeah, if they're command hallucinations, and this is not funny, if they are command hallucinations, you want to know whether it's telling them to hurt themselves or someone else. In 1992, my daughter and I were crossing a bridge. We were crossing a bridge, the Tobin Street Bridge in Boston, heading to Logan. And out of the corner of my eye, I saw this figure standing on the rail. Okay, and we stopped. It was clearly a young person in her 20s, standing on the rail. And I had certainly enough training to know not to go too quickly. In any event, we got there, and after a very brief conversation, almost no conversation, this person looked up to her left, paused, and then jumped. That person was having an auditory hallucination. Okay? So if that person had been encountered earlier on and the conversation had taken place with a first responder or a policeman, perhaps that person wouldn't have died. Okay? So it's really important. That's one of the ways we talk with, we try to get professionals in the public safety and in the fire and EMS area to engage with that conversation that the person might be having. We talk to them about how to handle things like substance use and whether that is creating a problem and how. We talk about personal safety, their safety. We talk about the fact that this training is not about getting them to change their protocols.
What do you mean by that?
Well, every police department, stay with police departments, and this is mostly public safety to be concerned with, they have rules about what you do when somebody has a firearm. They have rules about whether you have to stay face to face with someone, or whether, as we would handle a situation, be not so physically face to face with them. We'd be a bit off to the side, right? We'd not want to put ourselves in that position. But they've got protocols, so we don't ask them to change their protocols. We're trying to help them develop more awareness that can help them avoid having to take it one step further physically, escalating the situation through a lack of understanding of what mental health is. We teach them about what PTSD looks like. Okay, part of that we teach because we want to work on the internal focus as well. There are some really significant numbers that involve police and fire in terms of things like suicide.
You want to talk about some stats? Before we talk about statistics, do you think this training is enough?
Well, that's a very good point. There's a national model that says they would like to see every police department in the country have all of their personnel trained in mental health first aid, and then that's 8 hours, and then they want another 20% of those individuals to take what is called critical incident training, CIT. And that's a model, we did that in Washington County. Our grants cover both. So that's a 40-hour training. That's a 40-hour training, very expensive to send staff there, but that means now you have a situation where it looks like it's going to escalate, and that individual can now call on an internal police department resource. Okay. Other jurisdictions will have licensed social workers, licensed therapists like yourself and me, and we will ride along There are people who are doing that now. There are
the state of Rhode
jurisdictions that are
Island?
doing that in the state of Rhode Island. As far as I know, Providence, Warwick, I think Princeton started it, and Central Falls.
Okay.
Okay,
So we have 15 minutes. I just want to pace us.
that's fine.
Okay. Oh, so we're going to talk stats and we're going to talk
So
internalization.
just so we have some understanding of this, why we need to do this. So in fire EMS, we know that their rate of suicide, death by suicide, is 6 times higher than the general public's.
And do you have the gender demographic and age range as well?
Well, I don't have that specifically here.
Okay.
But we know that death by suicide with men is much more lethal because of firearms. However, in the police world, women and men both have firearms. I've never seen a gender breakdown in public safety. We know what that looks like in the general population.
Right.
But to give you some idea of how prevalent it is, in fire EMS, six times higher, and about 40% more than the general population.
Yep.
And about 40% more, based on studies, probably aren't reported. In one 12-month period, back 2 years ago, we lost six EMS people, 4 from Rhode Island and 2 from nearby Massachusetts, Seekonk, Swansea, in just a 12-month period. And those were the ones that were reported. We lost them to suicide.
Reported by?
Family members.
Oh.
Reported by the way
Coroner?
the coroner reports them, okay? And there can be various reasons for that. There's a code of protecting the family members. When you think about it, we know this, one death by suicide has a ripple effect in the order of 135 people, okay? Peers, work, folks in the work environment, family members, extended family members, neighbors. So that's what you see in the fire EMS population. You'll see in the police, these are some scary numbers. So through 2015, nationally, we had an average of 125 to 150 deaths by suicide, or nearly 3 times as many as those that were being killed by criminal violence, by felons. So police officers.
Repeat that again for our audience.
125 to 150 deaths by suicide in 2015, and that's 3 times as many officers who were being killed by criminals during that stretch up through 2015. The latest numbers look like this. In 2018, it's up to 172. By 2019, it's 228. Those are the most recent numbers. So now it's about twice as many deaths by suicide. They're much more violence in terms of killing policemen in other ways. Just this week, the director of the FBI reported that the numbers now are still up in that 170 area. They've grown to 170, 180 deaths by criminals, on the job deaths, not deaths by suicide. And that a lot of those are being driven by individuals who are doing acts of what we would think of as domestic terrorism, but in ones and twos. Very hard to see a pattern of it there. So those are some senses of how big a problem this is.
It's going in the wrong direction.
Right.
These
It's
numbers are
definitely
going
in the wrong direction.
Yeah.
Very definitely going in the wrong direction for both of those populations. There are higher rates of divorce, higher rates of substance use. I mean, we could go on and on and on with these because they're all symptoms of PTSD in one way or another. Higher rates of divorce. I have, when I get a referral, I get referrals from 2 or 3 different sources to treat. In the fire EMS world, I get referrals from peers, direct peers, or from the fire marshal. I have a deputy, there's a deputy state fire marshal that's probably sent me 10 peers in the last 2 years, 2.5 years. We know that.
By the way, we're at 10 minutes, so.
Okay, so that's one of the things we've trained people in the fire, EMS, and police mental health first aid trainings. We've taught them how to talk to their peers. They will listen to a peer who eventually says to them, look, Joe, it's going to be awfully hard for me to get in the truck with you again, if, whatever that might be, often it's substances. I really need you. I really think we ought to get you to talk to someone. So that's one of the ways we get it. Unfortunately, in other cases, we get it from the guys who walk in and say, if I don't come here, my wife is leaving me.
Yeah, so is there like training in self-reflection or just, acknowledging that there is something?
It takes a while.
Okay. Is there a piece of that in this training that you do?
In the training, they learn to do that. The thing they learn most to do, and that they need most to do, is find a way to get them to treatment. Find a way to get them to treatment. There are an enormous number of people who die who have never been to treatment because the culture is, I'm supposed to handle this.
Right, and denial.
Denial
is a huge component.
Exactly.
In several mental health issues,
Exactly.
Illnesses. I don't even notice I'm lying. Is that what? I don't even notice I'm lying. Is that denial? That's
denial. I don't notice. I'm just doing my job. It's what everybody else does. That's why we go to the bar and we, after work, and we put down a few.
Yeah. All right. Anything else on that before we switch topics? Because we are under 10 minutes left of the show.
I think the only thing to point out is it's good for Rhode Island. We've got all these policemen being trained, and we're requiring it for the fire EMS.
Okay.
Give ourselves an atta guy.
So, do you want to talk about marijuana legalization? Do we want to talk about? Gosh, there's so much to talk about on that. Is that the direction you want to go in, or?
I think the only thing I wanted to say about that I should say about marijuana legalization is that if it happens, the good news about it is that everybody now is saying, yeah, it's dangerous. Everybody agrees. It's addictive. These are things that they were in denial of 5 years, 10 years ago. It's addictive. It's dangerous for adolescent brain development, young adult brain development through age 25. It is impairing. It's causing problems on the highway. We know it's also causing, it's becoming more and more prevalent in the blood toxicology of people who die by suicide. And we know that black market is still going to be there, and gray market is still going to be there for various reasons. So those are things that everybody agrees on now.
Why are we trying to legalize it? Not me, but why? Why? So this is where now? This is in
the bottom line is money.
But where is this legislation now? The General Assembly?
The legislation is in the General Assembly. There are proposals by both the governor and the perennial proponents of it, Senator Miller on the Senate and Representative Slater in the House. Okay, and there's some differences and there's some questions about how they're going to handle that. But the biggest problem is that they are giving all of the retail point of purchase functions to private businesses, commercial businesses. And so depending on which proposal.
What does that mean? Elaborate on that.
So you're going to have retail points of purchase in
which would look like what?
35 or so if it's the House bill, up to 75 or 80 if it's the governor's bill over the next 2 or 3 years. So there'll be retail points of purchase. What happens with the commercial model is that it's a company. It's got a profit motive. It's got a marketing guy. That marketing guy's job is to increase use of an
increase sales
of an addictive substance. We're supposed to be managing addiction growth. We've already got the highest rates in the country. We're among the highest rates in the country in youth use of marijuana, for example. And we know that from Canadian models that, because in Canada, some of the provinces are working with commercial models at point of purchase. Others, they're state controlled. Think of New Hampshire liquor stores. So what we're finding out is the rate of use in Canada for a province that's commercialized have gone up in 4 years to, where is that?
Yeah. We'll talk about how does it trickle down. You have to be 18 to purchase marijuana, correct? If it is legalized? So
21 in Rhode Island.
Oh, 21 in Rhode Island.
In Rhode Island, it'll be 21.
So you're saying it's going to trickle down?
What I'm saying is that if you're a marketing guy, your job is to find a way to get more and more daily to near daily users. Those are the guys that are the market base. Your job is to increase market share, increase use, increase the bottom line. Those are your jobs. That's your whole reason for being there. And while the legislation throughout all of these legalized jurisdictions here and abroad say that there's control, you're going to be able to control that. You're limited in what you can say. You're limited in where you can promote. There's a rule in Rhode Island, you're not supposed to have billboards with pot on them. You can go up, just on the way up here, 3 billboards on 95. You go on 195. In Rhode Island, the billboards are for going to Massachusetts and getting what those rules aren't being. That's an example of a rule that's not being applied. But when there was so Alberta is a commercial model in Canada. This is the only place we could find really good direct comparisons right now, and these came from Rand Corp. 21% is the use is up 21%.
We have 1 minute. Yep.
Up 21%.
Wow.
In Quebec, it's just up 10%. So that's
These are minors.
these.
Right?
No, these are users.
Oh, users. Okay.
These are users. The use rate, how much of it's getting to the minors through gray market, is another conversation entirely.
Okay.
So my belief is that we really need to let the state control at point of purchase, just like we have a single source for every school district in the state for the food program. That's not 39 different food program contracts. That's a single contract. It's a management contract. Same ideas you see on a superhighway with rest stops.
Right.
Management contract.
Mike, you have to come back because we have so much more, so much more to talk about.
Well,
yeah. So
I'm available.
yeah, we're going to bring Mike back because look at all my notes. We have so much more to cover. I'm Darlene DeRosa. Oh, you want to say anything to our audience before we wrap up?
Stay well. Remember, there's no health without mental health.
I like that. No health without mental health.
Not mine, that's
Catch
Sue
us
Orban.
on Vimeo, YouTube, and Instagram at State of the State RI. Thanks for watching.